The real pie in the sky is prevention of that non-muscle invasive bladder cancer. So to me, upfront prevention in some way, whatever we could do genetically or preventatively, I think that really is the big next step. But once you have that diagnosis, then to get a treatment, just as Betsy said, that is definitive.
Hello and welcome to our Winnovations podcast. I'm your host, Dr. Kyle Richards, and we are excited to bring you part 2 of Advancements in Bladder Cancer, The Future is Now, featuring Dr. Sam Chang and Dr. Betsy Coney. This is a continuation of the previous episode. We had so much great content that we divided it into 2. I think you'll enjoy this conversation and learn some new and exciting developments going on in the rapidly changing area of early stage bladder cancer. There are some novel biomarkers that have come down the pipeline that I think are interesting and potentially can help us to better select patients for various treatments, maybe personalize their care. Betsy, anything that you're interested in the biomarker area? I know you're sort of exploring a few things on an academic front, but anything that we can use clinically, and then anything maybe coming down your pipeline that you're excited about?
Yeah, so a couple things. So one that we just started using at UW is the biomarker that is Vesta from Baylor Labs, which in the research world or papers was called the Computational Histologic Artificial Intelligence, or CHI biomarker. And so this is something that is used to help predict response to BCG. And in the study, they looked at people who were either treated with BCG or Gemdosi and looked at response to treatment based on the presence or absence of this CHI biomarker. And so they found that out of people who had this biomarker present, that those treated with BCG had an inferior high-grade recurrence-free survival compared to those who, it's not like a direct head-to-head comparison because this was an observational study. In the people who were treated with Gemdosi, there really wasn't a difference if they had the biomarker or not in terms of their outcomes. But again, for the people who had the biomarker present and then went on to have BCG, they didn't have as good of a response as the people who didn't have the biomarker present and had BCG, or either way with the Gemdosi. So that's something that we're just starting to use, and will be interesting to see how that plays out in the real world, and if it is offering more actionable guidance. And I think we'll continue to anticipate the bridge data and their translational other work that they're doing too, because I know they also are looking at biomarkers. And then the second biomarker type of thing that I've started using is using circulating tumor DNA, or ctDNA, which is available commercially from the Signatera lab. So there's a couple other institutions I know that I have friends at that are using this for high risk, and really we're looking at the very high risk non-muscle invasive bladder cancer patients, so people who have high-grade T1 or invasion into the lamina propria on their TURBT specimen. That invasion counts as being invasive enough for them to get this ctDNA testing. And in general right now, if the insurance is covering it, and if not, the company will just pay for it. So it is available to use clinically in that sense. I think it's a little bit different in not exactly a biomarker per se, but I'm using it more as perhaps to fill a gap in staging. And so with this test, the company is looking for really tiny microscopic bits of DNA from a patient's tumor. And we started using this in the metastatic space for monitoring response after treatment, and now it's trickling down into earlier and earlier stages. And so theoretically, somebody with a non-muscle invasive bladder cancer we don't anticipate that they would have any circulating tumor DNA detectable. And so that's why I think of this test as more highlighting a need for staging, and that is because these very high-risk non-muscle invasive bladder cancer patients can be understaged, and so that's how I'm using that.
It'll be interesting to see how that plays out, Betsy. I think it's a great idea. We definitely have a lot of issues with accurate staging on these patients for sure. So kudos for getting that rolling. What about you, Sam? Any thoughts on the Vesta? I know you were involved in some of the research on that. What are your thoughts?
Yeah, I think there are probably three broad areas for these markers. One with the circulating tumor DNA that Betsy mentioned honestly, for invasive, more advanced disease, monitoring not only disease risk, but response to therapies, hopefully de-escalating therapy when needed and initiating it early before any clinical response. I think the second area are in these risk categorization kind of both prognostic and predictive markers like the Vesta study. The Vesta study, I think, will really be helpful for those individuals or providers who are having trouble getting BCG. And if you have a limited supply and you have a patient who clearly is less likely to respond to BCG as opposed to someone who's more likely to respond, then it helps you in a fair distribution, or at least attempting to be fair in distributing your supply of BCG. A corollary to the Vesta test also looks at disease progression risk. Individuals whose tumors may be more likely to become invasive and or even beyond that may have early invasive and recurrent disease. Well, those are patients, perhaps you have a T1 patient that is much more likely to have a high risk score. Perhaps they end up getting a timely cystectomy and actually avoiding or not doing intravesical therapy. But to me, the holy grail still is a urine marker. You pee in a cup, you tell me if you have cancer, yes or no, or you tell me if your cancer's back, yes or no. We're not quite there yet, Kyle, in my opinion. I'm curious to see what you and Betsy use. No, let me phrase that. I'm more curious to know what Betsy uses, less that you use. But either one, I'd want to know what you use as a urinary marker. We use the Pacific Edge product, and we're going to start using the Vesica product called Assure MDX. They seem to have the best combination of sensitivity and specificity, but I think overall that still is, to me, the area that requires continued study, and yet there hasn't been a clear one yet.
Now, Sam, with all these insults, that's not going to get you off my program. So I'm just going to keep coming back. So
all right,
yeah,
we'll keep
that in mind.
All right.
That'll get you nowhere. But I do appreciate the jabs, and and I was going to make fun of Vanderbilt football, but I don't think I can do that this year.
Oh, well, and I'm glad that we're recording in 2025 because it does occur about once every century. So we're a quarter way through this one, and we matched what we did about 60 to 80 years ago. So we look forward to it. No, seriously, I would like to know what you use and Betsy uses, because I think it is a real question that is tough to answer.
Yeah, go ahead, Betsy.
Yeah, I do not use any urine-based biomarker tests at this point, besides just doing cytology when indicated during the cystoscopy procedures. But I think that conceptually, for really monitoring for recurrence, using a urine-based test would be awesome. And I think that it probably would be good and may need to have the same sort of methodology as the circulating tumor DNA testing, in which it's really a patient-specific signature derived from their own tumor that really makes the specificity and just, I think, really helps with the testing. Although a patient agnostic test, like what's commercially available right now, those may play more into the screening or workup, such as people with microscopic hematuria, and do they all need a cystoscopy? that kind of field. So I do think there could be a role for both, but I do not yet use any in my practice.
Yeah, I've been using urine cytology as an adjunct to cystoscopy, so not replacing cystoscopy, but I am eager to see. I know CX Bladder, which I think is the Pacific Edge product, some of their data looks pretty strong, and I think it would be nice to not have to do as many cystoscopies as we do, because there's certainly some morbidity associated with that. So it'll be interesting to see where the studies come out. I do think we want to talk about our last segment, the BCG unresponsive patients. And by my calculations, I believe, I was just looking at this, I think 4 FDA-approved drugs for BCG unresponsive non-muscle invasive bladder cancer in the past 5 years, and probably more coming in the next year or two. Betsy, what do these patients look like in real clinical practice, and what kind of unmet needs exist for these patients?
So for BCG unresponsive, for people who have BCG unresponsive bladder cancer, it's also a pretty broad spectrum, and there will be some people who have really terrible disease, maybe high grade T1, and they didn't respond to BCG, and that's a very high risk type of non-muscle invasive bladder cancer. I think also some of the challenges with the cancer itself in this space are if the cancer is involving the ureteral orifice or prostatic urethra, they may not be technically eligible for some of the newer things, and also it's just harder to eradicate those locations with the intravesical treatment. And so there are certainly some situations where it's like, doesn't really matter how many new FDA-approved drugs we have, because none of them are going to work for that. But on the other hand, there will be people who just have these recurrent high-grade TA tumors, and it doesn't seem like they're really ever going to progress to something, hopefully not, at least something more invasive, but it's hard to just keep them tumor-free. And so it is nice that we now have these options, and usually I use gemdosi as my first option after BCG. I really have not yet gone farther down the line, but we do have some of the other ones available, and I may have them come up as my time in practice continues to evolve.
Yeah, you've been in practice for a little over a year now, so it's too soon, right? You haven't acquired these patients quite yet. I wanted to try something new here, kind of a rapid fire sort of. I'm going to say a word, and then we go back and forward, and you just tell me the first thing that comes to mind. And this is all about BCG unresponsive patients. Do you guys want to try that out? Sort of rapid fire?
Rapid fire. I thought you were going to say Kyle Richards, and then I was going to say awesome.
But well, we might. We could do that.
I'm ready for BCG. All right, BCG unresponsive.
Yeah, BCG. All right. BCG unresponsive. And it could be maybe a sentence about the whatever I spit out. How does that sound?
Okay.
So kind of a quick answer. The first thing that pops in your head. All right, Sam. We'll start with you. Cystectomy.
Morbid.
Betsy. Cystectomy.
Now I'm just gonna say what he said. So I'm gonna say, I'm as I said a minute ago, I haven't had people really go on after gemdosi, but I have had these very bad, not high risk, non-muscle invasive cancers that are involving the ureteral orifice, and those are all my people who are getting cystectomies, all my non-muscle invasive people. So I'm just picturing these UOs with tumor all over them,
kind of marching up the ureters, and you're getting that disease out. Doing God's work, as I like to say. All right, I'll start with you on the next one then, okay. Betsy. Let's do pembrolizumab.
Ooh, side effects and doesn't work that well.
All right, Sam. Pembro?
Really? Question mark?
All right, Sam. We'll flip it back to you. Gemdosi. Betsy already said her gemdosi, so gemdosi.
Default chemotherapy combination. that definitely has some efficacy. How much unknown. Sorry, that was a little long, but
No, that's okay. That's okay. That was good. All right, Sam, we'll start with you. Adstiladrin.
was that back to me or is that to Betsy?
Sam.
Sam, okay. Adstiladrin. Favorable dosing schedule with a well-tolerated therapy.
Betsy, Adstiladrin.
I'm thinking of our VA population. That's where I've used it so far, and the veterans who are coming from all over. And it is nice because of the dosing strategy.
Yeah, I think that's probably the one thing I always think of with Adstiladrin is it's only 4 doses a year, so once every 3 months. All right, Betsy, let's start with you on this one. Anktiva.
You still need BCG.
Sam, Anktiva.
Longest duration response so far.
Good. Yeah, they've got pretty good responses out to 24 months is the latest data that I've seen. Betsy, Inlexo, TAR 200.
Oh, TAR 200 pretzel. That's it. I just think of the pretzel. I just picture it.
Not cheese filled is what I think of. Sam, Inlexo, TAR 200.
Pretzel chemotherapy. Yeah, I'm going to leave it at that. Pretzel chemotherapy.
All right, that I think that concludes our rapid fire session. That was kind of fun. I mean, I enjoyed it.
Okay, I'm going to throw one out at you. Ready?
Yep, you can. All right, you can take over.
No, I'm just going to ask you. Combination IO plus BCG.
Ooh, is that for me or for Betsy?
That's for either one of you. And then I'll say CREST trial or Potomac trial. Both show advantages of an IO plus BCG versus BCG with maintenance, both arms. Thoughts?
ESMO, high side effects, systemic agent.
Betsy?
Yeah, it's a lot with the systemic agent, and I'd have to really want to avoid the cystectomy and not think I could use any of these other intravesical options.
Follow-up question. 5 to 10 years from now, let's go 5 years in the future, because after 5 years, I'm going to be retired. 5 years from now, for somebody that comes in that's BCG naive, high risk, companies are banking on this, Betsy, they're banking on this. Are you going to use a combination IO with BCG, or are you going to do BCG by itself? Because Merck has already ramped up their production, so you don't have to worry about the BCG, but do you add the IO or do you not? 5 years from now, 100 practicing urologists, how many are going to use the combination and how many are going to use just BCG?
Not many are going to use the combination, but if there was a really good biomarker or something where we knew that somebody had really perhaps more invasive, non-muscle invasive, of like a high volume, high grade T1, and they wanted to try everything to preserve their bladder, that would be one indication that I could think of.
Kyle?
Yeah, I think she's good. We're keeping her for sure.
Yeah, agreed.
That's what I think. Yeah, I think it's this. I struggle. I mean, I've started to see some of the data that that you're alluding to that I think was recently presented at ESMO, and I just have real concerns about the systemic toxicities. We're talking grade 3 serious adverse events in over 20% of patients. So I agree with Betsy. If we can select out the really bad actors, you could probably justify that. The ones that we know are going to progress or maybe even have some of those more aggressive subtypes that are not muscle invasive. I've been seeing more recently diagnosing patients with like sarcomatoid T1s that, these are high risk tumors, but patients would, in general prefer bladder preservation. So that might be a good population to really look at being more aggressive with.
Yeah, I agree with you totally with both of you. The sub selection for that combination of wanting to have their bladder preserved, not having a lot of symptoms, and yet really worrisome disease. I think that combination is built for getting combination therapy.
Yeah, I'm glad you brought that up, Sam. I think that's important. And frankly, I mean, we could probably talk all night about bladder cancer, but my wife's going to think I have forgotten about her. So we need to unfortunately come to an end here. But I do want to get your one last question from each of you. I like to ask my guests sort of their pie in the sky view. And obviously, this is for bladder cancer. So if you could invest unlimited funds or resources to helping patients with non-muscle invasive bladder cancer, where would you put the money? And I'll start with Dr. Coney.
Wow. Yeah, this is hard. I honestly I feel that I wish I was more creative about this. I wish that there was just a really good effective treatment for the non-muscle invasive bladder cancer tumors for people who have those that would just be really definitive and not make them have terrible side effects. But I don't have anything more specific about it.
I think that's fair, and we certainly need treatments that are effective, that have decreased side effects, and also hopefully cost effective. We didn't get a chance to talk too much about the sort of financial toxicity that we're sort of seeing with some of these high cost pharmaceuticals, including a lot of these treatments for BCG unresponsive disease. Now, Sam, as your career has grown and you've seen a lot of change in urology, what's your sort of pie in the sky view for patients with non-muscle invasive bladder cancer?
Yeah, now I think it would be the issue. The real pie in the sky is prevention of that non-muscle invasive bladder cancer. So to me, upfront prevention in some way, whatever we could do genetically or preventatively, I think that really is the big next step. But once you have that diagnosis, then to get a treatment, just as Betsy said, that is definitive, done. You get it. You have built up either immunological memory or some other change so that you will no longer have this recurrent and or progressive disease. I think would be great. If we can't get to that treatment thing, then whatever we can do to better diagnose and survey, to decrease the burden of cystoscopy, scans, et cetera, I think that would be a smaller piece of the pie. You give me the whole pie, I want to prevent it. You want me to give me a bigger slice? It's like, okay, something definitively to treat, but a smaller piece of the pie is give me a little better risk stratification, prevent surveillance over burdensome kind of cystoscopy schedules, and I'd go with that.
That's beautiful. I think that's a good way to end. And I just want to say thank you to Dr. Sam Chang and Dr. Betsy Coney for being our wonderful and gracious guests on our program.
Thank you. Thank you so much for having me.
It was seriously a real pleasure to be able to talk to both of you very, very much.
And I also want to thank our producer and editor, Sandra Miller, as well as Dr. Steve Nakata, the chair of the Department of Urology at University of Wisconsin. Signing off, once again, this is Kyle Richards, your host of Winnovations.
Winnovations is a production from the Department of Urology at the University of Wisconsin-Madison School of Medicine and Public Health. Thanks for listening.